My primary interest is young adult hip surgery, but within that I see a lot of patients coming in with dysplastic hips. So within that we see patients primarily with acetabular dysplasias, but also femoral dysplasias, and one is often coming with the other. The majority of dysplasias we see currently are due to infection, trauma, or iatrogenic. They're acquired dysplasias, but we do still see some congenital hip dysplasia in the UK. It's much less now because babies are screened at birth, at delivery, to look for clicky hips. And if they have any risk factors like diabetes or breech or any other risk factors for dysplasia, then they are ultrasound scanned within the first week of birth, and then treated quite aggressively by our surgical services. So I would say that within hip dysplasia we see grades between 1 and 4. I think grades between 1 and 3 are fairly innocuous and mild hip dysplasias. It's the grade 4 hip dysplasias that cause the most interest among surgeons, because they're the most complicated ones to try and manage surgically. So this is a unilateral Crow-4 hip, and we see. I think I've seen this 3 times now as an operating consultant in the UK, and this is because they're not coming through from our local populations. These are patients that have come in from overseas with their hip dysplasia, and because of that, they don't have the same level of understanding of the problem. So they come with a short leg, and often with back pain as a result of the secondary spinal scoliosis. And that makes for a very difficult consultation, because there isn't an operation that we have that can restore their leg length and their coronal spinal balance. So you really need to be very specific when you're meeting them as to what their clinical problem is. If you've got a Crow-4 hip, the ball isn't in the socket, it's a pseudoarthrosis. It's much like a Girdlestone hip, and therefore it's not painful. And in fact, the pain they present with is primarily from their back due to the short leg. Patients who have had a short leg for many years have been compensating for a long time. They may have a shoe raise, and they have managed to get on. Often they're looking for cosmetic reconstruction rather than to make their hip more comfortable. So if you imagine you've got a 12, 13, 14, 15 centimeter leg length discrepancy, and you plan to do an operation where you can maximally increase their leg length by 4 centimeters, they're still going to be left significantly short afterwards. And the end result is that these patients can be very unhappy with their surgical outcomes. So my general advice with Crow-4 hips is to try and avoid operating. If they have bilateral Crow-4 hips, this is a more interesting situation, because again, it's very rare, but the patients we do meet with Crow-4 bilaterally often aren't even aware they have it. So I've seen 2 patients in the last 6 years that have come in for knee replacements, and when I've been examining them, I've examined their hips as well for completeness. And the hips, while they've been stiff in abduction, the hips have been moving comfortably. And when I've arranged for an X-ray to assess why they're so stiff, we found that both hips have been dislocated for their entire lives, and no one's picked it up before. It's never been assessed or treated. And I had a patient 5 years ago who'd had 4 normal vaginal deliveries with bilateral hip dislocations. So these patients are generally happier. And again, I don't think they need to be considered for a surgical procedure. So, as I said to you earlier, most congenital dysplasia is picked up in following delivery, but there is a small number of patients who develop dysplastic hips during their adolescence, and we assess this by measuring the lateral center edge angle of the hip and the acetabular index to give us some measurement of the depth of the socket. And patients who are deemed to have a borderline or dysplastic hip I then offered the potential for a periacetabular osteotomy, which works very well in terms of improving the depth of the cup and increasing the hip coverage. And so again, we're seeing these patients presenting for surgery in their 50s and 60s now with abnormal anatomy secondary to their initial hip surgery. So with the advent of hip arthroscopy and hip impingement science, we're much more familiar now with how hips can impinge and how best we can change the hip shape to prevent impingement and ongoing labral damage. So one of the things we're more aware of now is acetabular retroversion. So if you look at the plain X-ray on the left, you can see that the ischial spines are more prominent, and there's a crossover sign where the anterior and posterior walls of the acetabulum cross in the center of the femoral head. And this is interesting for me as a young adult hip surgeon, because I recognize it early, and I can offer them surgery to trim down that rim and repair the labrum. And if I'm not winning, there is again the potential for a periacetabular osteotomy to correct the version of the acetabulum in the AP plane. But beyond that, if I meet a patient who's developed arthritis with retroversion, I'm much more able to pick that up early. And I'm not finding that during the surgery, I'm suddenly in a position where I've got very little anterior or posterior wall, and I'm struggling to get a well-fitted acetabular component. So with a case like this, gentlemen, I have several considerations when I'm planning the case. The first is, where is the acetabulum? How high is it on the pelvis? Am I going to keep it there, or am I going to try and bring it back down into the true acetabulum? I need to think about how much coverage there is. Do I need to medialize the cup? Do I need to medialize it through the medial wall of the pelvis to get me some more bone to cover the top of the acetabulum? I need to think about the version of the cup. If the acetabulum is very retroverted, again, I may need to read much more anteriorly to try and get myself into some more healthy host bone. On the femoral side, again, I have to think about the version of the hip. If the hip's very retroverted, then as the hip flexes up, the trochanter is going to impinge on the pelvis and cause dislocation. If the hip's very retroverted, then again, the trochanter can impinge in abduction and external rotation, causing the hip to dislocate. So I may want to consider a femoral osteotomy to derotate the proximal femur and put it into a more neutral position and prevent impingement. If I have a very abnormal metaphysis and I'm planning to use an uncemented implant, I may need to plan how I'm going to maximally fit and fill the metaphysis to get the best fixation and the longest lasting implant, particularly in a patient who's maybe 20, 30 or 40 years old. I need to consider the leg length. Now, there's a limit to how much I can lengthen the leg. Historically, we're all taught that you can only lengthen 4 centimeters, but I've looked at the science behind this, and it's based on a paper published pre-1900s, and you know, the surgery at that stage was not particularly as aggressive as perhaps we're doing today. So but everyone wants to avoid a sciatic nerve injury with this sort of surgery, so we are very mindful about what we're doing, and particularly at the planning stage. This patient's got a fixed adduction, and so I need to be planning my releases. If I take the head away, is the hip going to come out into full abduction, or am I going to have to release the adductors at the end of the operation percutaneously to allow the hip to come out into neutral? I need to be thinking about the spinal alignment. If a patient's young, he or she has the potential to straighten up once I correct the hip, the leg length, and the pelvic obliquity. If a patient's in their 70s and 80s, there's no point in trying to address that. You're not going to win, it's not going to change. And you may tip them over into a worse position in terms of their sagittal alignment, which they won't thank you for. I need to be thinking about any scarring around the hip from previous surgery or from infection or from injury. I need to be thinking about the quality of the abductor muscles. Are they good, thick, quality muscle that's going to be able to work once I've reconstructed the hip? Or is it full of fatty change? So abductor muscle that's where the muscles all turn to fatty tissue, you can pick up on an MRI scan, and that will give you some idea about the level of function after surgery. And lastly, I need to be thinking about whether I'm going to approach the hip from the front and isolate and protect the femoral artery, or am I going to come to the hip from the back and primarily try and protect the sciatic nerve? So as I said to you earlier, as we were talking, I generally use a posterior approach. As I say, it's extensile over the pelvic brim and down, right down as far as the knee. I can get to any pseudoacetabulum around the ilium, and I can gently lift and mobilize the abductors and the femur while minimizing the necessary trauma to the muscles around the hip. So within the acetabulum, I've got a ladder of reconstructive options, which we use for primary hip replacement, but also for revision work. So we can reconstruct any acetabular defect. Within primary hips for dysplasia, I rarely need to use augments, but they're there and they're available. My main decision making is around where I'm going to put the cup. If I'm going to seat it high, I'm changing the center of rotation, and that changes the forces across the hip and can result in an earlier failure of the reconstruction. Historically, there's been a lot of work using autograft, using the femoral head to reconstruct bone around the hip. I have no experience of this. I was always trained to use the host bone because we can now get such good fixation with uncemented implants and screws that it's unnecessary to use autograft. And when I have seen it, it's always been for revising someone else's previous autograft fixation. Each time I've seen it, I've seen a mess of broken screws and failed bony union. So this is a paper I picked up that was published very recently from the Mayo. They've got a big series of autograft reconstructions, but have only managed to achieve 60% survivorship in 20 years, which I think is probably quite low for what we're seeing now in the young adult population. So this case is a lady with neglected avascular necrosis, and she had some other medical problems, which meant that we had to delay her surgery for a period of time, during which she started to lose more and more bone around the pelvis. So as you can see, she's very short on the left, and my reconstructive goals are really to restore leg length, bring the cup back down into the acetabulum. This lady's a low demand patient, so I'm not going to make any big effort to bring the cup down. I just want to get her cup into some good, strong host bone. This is how I plan it using OrthoView software. And really, the first thing I do is look for where I can sit the cup most confidently with good host bone. And then I start thinking about where I'm going to position the femur, the femoral component in the femur, to restore leg length and offset most accurately. And so once we've reduced the hip, this is actually a 44 millimeter cup and a 22 millimeter head. So we've had to use very small implants, the sort of thing that Charney would have used in his day to try and get a reconstruction. But the cup's now under healthy host bone. I've not had to use any autograft, and I haven't had to medialize the cup very far through the pelvis to restore the center of rotation. This lady has a clear femoral dysplasia. Again, we see this more commonly in the UK following previous surgery or from fracture or infection. It's unusual to see congenital dysplasia or developmental dysplasia like this. There's been a lot of interest in managing these cases with the hip resurfacings in the UK because it's easy. You just take the neck off, put the cup in, put the head on, and off you go. But in patients in their who in their 50s and 60s, because of the bow of the femur, they begin to develop stress fractures on the lateral bow, and this causes the reconstruction to fail early. Obviously, I tend to use these ESROM hips. Now, this is an uncemented implant. The surgical technique means that you triple ream the femur. You ream down into the distal femur, Then you ream the metaphysis, so we get maximal fill of the metaphysis of the femur, and then we use a side reamer to ream out the calcar. And this means that at the end of all this, we can sit an implant against host cortical bone all the way, and gives us a very solid reconstruction. Now, this particular implant is fluted, and these splines, they grip the distal femur. So this implant becomes rotationally stable on the distal femur. So I can position this modular metaphyseal sleeve wherever I want in the femur and not have to consider distal stability, which means that, hang on, which means that no matter which way the femur is pointing, whether it's retroverted or anteverted, I can cut the neck, position the sleeve in the metaphysis, whether it's pointing backwards or forwards, and then separately position the stem itself into any position of anteversion I like to restore normal version and therefore normal hip biomechanics. This is a very powerful reconstructive tool. The implant has a coronal split in it as well, so that as the distal stem impacts into the bone, the two sides of the stem come together, and it has this additional hoop stress which controls the rotational stability. This sleeves come in multiple different options. The stem itself, the centerpiece, comes in multiple different offsets and lengths, so you can reconstruct even the most complex hips in patients with Down syndrome or dwarfism, or any of these other more complex abnormalities. As you see here, I've positioned the metaphyseal sleeve facing laterally or medially, anteriorly or posteriorly to get the best reconstruction. So for this case we were just looking at, you can see we've done an osteotomy, we've translated the bone to best restore neutral alignment, position the cup in the normal center of rotation, and then control the rotation of the proximal fragment of the femur using the metaphyseal sleeve. And you can see on the other femur that we've obviously done this 6 months before, and that's healed with now a straight femur, which will protect him from stress fractures in the future. So this is a more common Perthes type hip, and again, the primary problems the patients will be complaining of is a short leg and restricted range of movement. I use a CT to assess the version of the hip, and in fact this isn't desperately retroverted, but often they can be. And then it's a simple template with the software, and then we can reconstruct and reproduce leg length very accurately. This lady had a congenital dysplasia and has had 3 previous surgeries, the last of which was to remove the metalwork, which has had a variable degree of success. But she's now presenting with a stiff hip, a very anteverted femoral neck, a leg length discrepancy, and a complex acetabular reconstruction as well. So on the CT, again, both hips are anteverted, but the left one is significantly more so at 50 degrees. And I can use this Esron stem, first of all, to ignore the anteverted femoral neck by positioning the sleeve anteriorly, and then positioning the femoral stem within the sleeve in a more neutral 10 degrees anteversion to reconstruct the hip more anatomically. And of course, we can bring the leg length down and give her a much more normal gait. So this gentleman's Chinese, so it actually happened in the UK since he was in his teens, and had been running his own fish and chip shop. But aged 58, he decided he'd had enough and wanted to retire, and he came to clinic for an opinion. His legs scissor, so when he sits in the chair, he sits almost cross-legged by default, because this right leg comes over the front of the left the whole time. And when he walks, he finds it very difficult to hold a straight gait, if you like. So again, the acetabulum has, he had a septic arthritis as a baby. I think he was 3 or 4 years old. His story is not very clear because obviously he hasn't got any relatives locally to tell him, but he had 2 or 3 surgeries resulting in this position of the hip that he's in now, and there was no metalwork there, but the acetabulum is obviously quite high. The femoral version is very anterior, and the end result is that he's got a very narrow offset, and the trochanter is clearly impinging on the pelvis already. The fixed adduction is partly due to the shape of the femoral head, because it's and the impingement around the trochanter, and partly secondary to the tight abductors. So the CT scan gives us a clear picture of the femoral version. It also shows that trochanter is very near to the pelvis and will impinge unless we do something about it. So I'm already starting to think about a femoral osteotomy to correct the femoral version. The acetabulum has got some bone above, so that I can reconstruct into some healthy host bone here, and I'm very near to the native acetabulum down here. The other issues with him are, we can see that the gluteal muscles on the left are very thick and normal, and on the right they are very thin and a very poor quality. But and again, we can see them here, but they are present, and they aren't. And on the MRI, which I haven't got a picture of, they were functioning. So there was some potential there for recovery of his abductor function. My next decision is whether to go in from the front or the back, thinking again about the sciatic nerve, but I'm much happier going in from the back. I like to see the sciatic nerve, and for a case like this, where I'm going to be lengthening him a significant amount, I really want to be able to mobilize the sciatic nerve and feel it during the surgery to make sure it's not coming into my surgical wound, it's not at risk, and at the end that it's not under any significant tension, which would cause obviously a palsy for him. So I've managed to bring the, so I did do an osteotomy. So, well, first of all, we put the cup in, and that was relatively straightforward. Getting down into the hip joint through the scar tissue and mobilizing the femur was quite complicated. But then the osteotomy allowed me to mobilize the femur very freely. And in fact, what I did was prepare the distal femur first, so I had a stable hip to reconstruct, then start to prepare the proximal femur separately. And once I had both sides prepared, I could line them up together to decide how much distal femur to resect. If I tried to lengthen the whole femur, the end result would have been lengthening the sciatic nerve too far, and I would have given him a palsy. So preoperatively, we discussed the fact that we weren't going to be able to restore his full leg length, that he would need to continue using a shoe race, but a smaller one that he'd be able to manage better. But primarily, he wants to be able to stop his the scissoring of his legs, to improve his pelvic obliquity and enable his secondary scoliosis to begin to neutralize. And I guess this went well, considering the complexity of the case. The one problem I found was that once I prepared the proximal and distal femur, when it came to impacting this stem down into the femur, the metaphysis didn't come down as far as I wanted. So I put a little bit of graft in here, and post-operatively it went on to unite. I think this is 2 months later. So he's much happier and accepts the fact that we haven't restored his full leg length, but his overall mobility and biomechanics are much better. This is another Perthes case with a quite significant bow on the femur as well, which we had picked up on preoperatively, but hadn't planned for as well as perhaps we could have done. So again, a very anteverted femoral neck. She's got a significant scoliosis. This lady was only 38. In someone this age, I'll try and do some lateral flexion views just to get an idea about how mobile some of these segments are. So we can start thinking about, if we neutralize the pelvic obliquity, is her overall coronal alignment going to significantly improve, particularly in someone who's young like this. So on table, we've got a very straightforward reconstruction of the acetabulum. We successfully reamed out and reconstructed the proximal femur without an osteotomy. We've got a good distance here. It wasn't impinging. I was very happy with that. You can see this, the split in the stem where the two sides of the distal implant come apart and are pushed together in a tight cavity. During the operation, I heard a loud crack, and I could see there was a crack up here at the calcar. So I assumed that I'd cracked the calcar and put these two cables on, and saw this X-ray and was very happy that the stem bypassed the distal end of the fracture, and then we had a stable reconstruction. On the ward, she was straight leg raising, and she was able to walk for me independently on the ward. So I was very happy that she had a stable reconstruction. But 5 days after discharge, she represented with this, and clearly this has propagated and deteriorated. Again, the stem still appears to have some stability. I think in retrospect, if we look back at this lateral view, you can see the cortex is very thick and strong here, and anteriorly, though, it's very thin. And it's these changes in the stiffness of the bone, in abnormal bone, that we're not as easy to, which aren't as easy to recognise, basically. And so when you're preparing a stem as you would normally, this is something that is easy to miss, and you don't pick up the warning signs quite so easily. So anyway, I plated this with this is a Zimmer NCB plate, which allows me to place screws front and back around the femoral stem, and some cables to hold the bone while it heals, and it's healed very well. And her overall recovery has been excellent. She's independently mobile, and her spinal alignment significantly better with her obliquity and her leg length. This gentleman was 59 when he came to see me. He'd been to several centres around London and the southeast, looking for an operation. He was coming in saying that his hip was painful, but clearly his hip is to all intents, it's arthrodese. So the real symptoms he was struggling with was low back pain, and he'd been working as a train driver for 30 years successfully with this hip as it was, following a motorcycle traffic accident in his 20s. He'd been treated on traction, and this had united in this position. Now, he's clearly got some shortening. There's clearly going to be difficulty reconstructing the acetabulum, primarily because the width of this acetabulum was 80 millimeters. So that's bigger than most of the revision cuts we have on the shelf. The CT scan shows that there is callus all around the hip. So planning whether to come into the hip from the front and protecting the femoral artery, or coming into the hip from the back and protecting the sciatic nerve was an interesting dilemma. In the event, I came in from the back, taking out this part of the posterior wall, but the hip still wouldn't rotate or translate because of the bone at the front. I had to cut the neck in situ and then enable the hip to slowly translate anteriorly across there. Take out the femoral head piecemeal with an osteotome, and then use the osteotome to come through the anterior wall of the acetabulum so that this bone here wouldn't then impinge, and take this out piecemeal nervously around the femoral artery. The other interesting aspect of this case is that the femoral head is healed outside of the or posterior to the pelvis. So here is the back of the ilium, and the center of rotation is well out of the pelvis. It really should be back here to restore the normal center of rotation and allow the hip to function better and last longer. So I spent some time planning this, and I used a cemented stem, which gives me a lot more freedom in terms of version and leg length, so I could concentrate primarily on the acetabular reconstruction. I've actually used these augments for this case, which is unusual for a primary hip. And I position one of these augments behind the cup to bring the acetabular component back under the pelvis, and back, being the center of rotation back into the correct sagittal alignment. And we've managed to, despite this side of the pelvis all being caved in, we've managed to restore him back to his normal offset. So the abductor muscles, where they were quite weak and wasted preoperatively, have got the best chance of function and restoring normal gait. So this last case is a chap who is a very sad story. Age 13, he developed a slip tip and had presented to his GP, who wasn't very impressed, and had written to the headmaster of his school and said that he was a shirker, and that if he complained of hip pain, they should ignore him. Anyway, the eventual outcome was that the hip turned out so far that when they came to try to fix the hip, it fixed in a very poor position, and then the femoral head collapsed and failed. He then went to one of the pediatric limb reconstruction units, and they had 2 attempts at trying to reconstruct the hip, culminating in this attempted arthrodesis, which has also failed. They then tried to remove the metalwork, and again, obviously, that this metalwork is encased in bone, so they failed in that as well. By this point, he was struggling at school, and he then had a very sad adolescent life, and ended up living on the streets and had a drug and alcohol problem. But he, with the help of his family, was turning his life around, and came to see us when he was 40, and wanted to try and fix his hip. Now, his primary problem actually was this fixed adduction again, and like the Chinese gentleman, his legs were scissoring, which meant that he really struggled to walk at all and had a very poor gait, a gross pelvic obliquity and secondary scoliosis, but the potential to have some restoration. So you can see his leg length obliquity is quite severe. These 3D CT scans, they look very clever and impressive, but in fact they don't really help me very much with the planning of surgery. But in this case, I wanted to see how much of the metalwork was actually visible, because the first stage would obviously be to try and take this out. And I warned him that we may take the metalwork out as a first procedure, and then if we had to damage the femur to do that, or I wasn't happy to continue, I may have to stop at that point. But in fact, we managed to take it out in one go. I then wanted to try and take down the hip, the bone around the hip, to mobilize it, and try and bring him out to a more neutral abduction position, and then work on the acetabulum to try and reconstruct his leg length. So this MRI scan was looking for fluid around the metalwork, suggestive of infection, and looking at the abductors to see what sort of condition they're in. It's actually clear on the CT that you've got good muscle bulk here and very poor muscle here, but you can see this is muscle rather than fat up here, which made me feel more confident for him. We can see that there is an acetabulum of sorts there, and medialising the cup, we're going to be able to get it under some good host bone and get a good reconstruction at that level. And we can see that the femoral version is very neutral, but that there is bone in the anterior and posterior walls that would allow me to seat a cup confidently. So here's the reconstruction. Again, I've used cemented stem, primarily so I could ignore any metalwork that was sitting in the stem. This was all primarily in the greater trochanter, so it didn't really get in my way at all. But using cementing, I can ignore the proximal femur and concentrate on doing the more complicated acetabular reconstruction, taking out the metalwork, getting this into good host bone. The cement restrictor has slipped, and that's resulted in a large amount of cement, but poor interdigitation in this gentleman, unfortunately. But we have restored his leg length, we have neutralized his pelvic obliquity, and we have significantly improved his spinal scoliosis. Okay. So that's a series of cases that I presented from Frimley. As you can see, most of the cases we see now are acquired rather than congenital, because our screening services are so acute now. And most of the more complex cases we see in the UK are patients from overseas who have moved to the UK with their families and then present to us with a long-standing and often quite complicated clinical problem for us to solve. But part of my interest is solving these complicated problems and trying to get as good a reconstruction for the patient as possible. Have you got any questions about the case?
Thank you so much, Dr. Sturridge, for this very important presentation about a very difficult topic to treat. Before, sir, we move to moderation with Dr. Rami and Dr. Hussam, I have two questions, sir, if you allow me, please.
Of course.
First question, in dysplastic cases, do you routinely do soft tissue release before doing the hip arthroplasty?
So generally speaking, in a lot of these acquired cases, the hip is literally stuck down, and to get into the hip joint, I have to take down a lot of scar tissue first. So usually I go through the fascia, and then when I find the trochanter, I then basically stick to bone to come down around the femoral neck and onto the acetabular rim, just to get my exposure. And often at that point, the hip still won't move at all, and I have to either plan a neck cut in situ or start removing bone from the acetabulum or from the femoral head, just to get some space to be able to move the proximal femur out of the way to be able to reconstruct anything. So yes, I usually have to take down scar tissue before I can even start the case, absolutely.
Yeah. The second question, sir, please. We usually do acetabular reconstruction using bone graft, either from the head. We use more sliced bone graft from the head, or iliac bone graft from the iliac crest. But when you say I have to use an augment?
So I think augments aren't available everywhere. So I'm very lucky that they are available for me to be able to use them in where I work at the UK. Most hospitals in the UK don't have augments, but my background is part of my practice is revision hip surgery as well. So I'm very used to using augments to reconstruct complex acetabular defects. In a native hip, I use them very, very rarely. If I want to bring the cup down lower, so bring it from the ilium back down into the native acetabulum, then I may use an augment just to push it down and bring my center of rotation back down to where it should be. If I want to bring my center of rotation from behind the pelvis back under it, I may use one behind the cup just to push the center of rotation back in under the pelvis again. I found that a very useful technique as well. I think the bony allograft is a very well recognized technique. It's been around for a very long time. I have less experience of it, and the cases that I have seen haven't gone so well. But that may be because the cases I don't see don't present to my practice, and so I don't need to worry about them.
Thank you, sir. Dr. Rami, you are the moderator with Dr. Sturridge and Dr. Hussam also.
Mr. Sturridge, thank you very much for accepting our invitation, and thank you very much for the brilliant talk as usual. So I will start my question from the preoperative assessment. In case of bilateral hip dysplasia, what is the best workup plan for them? Do you usually request CT scan, or do you assess the spine? And templating, how would you template bilateral hip dysplasia?
So if it's a gross dysplasia like a Crow 4 hip, then I try very hard to avoid operating on this patient group, because their leg lengths are equal, their spine is straight, there's no gross, and their hips have pseudoarthroses, so they don't have significant pain. So you have to be very careful about what your indication to operate is. If it's a lesser dysplasia like a Perthes hip, or they've had like the femoral dysplasia I showed you earlier, then what I try and do is one hip at a time. So in the UK, we do operate on both hips at the same time for a fixed flexion deformity. But beyond that, we try and do one hip at a time because we want to minimize the risk to the patient, basically. If they have bilateral Perthes hips, then I would try and restore the leg length the same. I wouldn't try and lengthen them at all, so that when they are walking with their new hip on one side and the other hip still dysplastic, they're not aware of leg length discrepancy. And then when we come to the second side, I would try and keep the leg length the same, so the outcome is good, is better for them. So we would not operate on bilateral dysplasia at the same time, and it's quite unusual to see it now in the UK.
Yeah. I have received two questions about spinopelvic dissociation, one from Mr. Kapil and one from Mr. Imad. The spinal imbalance, is it either balanced or unbalanced, and each one of them is either rigid or flexible? Which case would you say to the patient, go fix your spine first and come back to me?
So the problem with hip surgery is that it's usually very successful. So the spinal surgeon will always say to you, do the hip first because you'll get a much better outcome than me. So it's difficult. The other thing is that when I'm assessing a patient's hip and spine, if they are very young, then they will still have some flexibility in their spine. I will do scoliosis views with the spine flexed to the right and to the left to see how much mobility there is and at what level. And then you can start counseling the patient that what you expect to improve in terms of their spinal alignment with a hip replacement. The two cases at the end there had very fixed deformities, and just correcting their hip to neutral neutralizes the pelvis and will improve their spinal alignment. But in a 70 or 80-year-old patient, you're not going to be able to achieve that. And if the hip you're replacing is on the longer side, then you have to be very careful that you don't lengthen them anymore. In a 70 or 80-year-old, I wouldn't try and shorten the hip, because if you try and do it without an osteotomy, you'll make the hip unstable and they'll dislocate. And an osteotomy is complicating an operation in an elderly patient unnecessarily, I think. So I would just try and keep the hip as neutral as I can. If it was the shorter leg side, then you can lengthen the leg with the hip replacement, and that does improve their what they consider to be their leg length discrepancy. But if you lengthen it too far, you will push their spine into a worse deformity, and they will feel unstable, and their back will feel worse. And so that's a big risk for you. In terms of hip joint stability after hip replacement, there's a lot of talk about this in the UK at the moment in terms of spinal fusions resulting in hips becoming more unstable in certain positions. But I'm not experiencing that in my practice. I'm quite careful about testing my hips very aggressively intraoperatively to make sure they are going to be stable. And I use 36mm heads, particularly in patients who I have a concern about. So anyone with a spinal fusion, or with Parkinson's, or some other reason why I'd be concerned about spinal stability, I'll use a bigger head. Yeah, but we're not seeing high numbers. Well, we're not seeing dislocation on a regular basis in the UK anymore, really.
Would you put the cup in more retroversion or antiversion with such cases?
No, so I position my cup primarily in about 30 degrees of antiversion, and I close it down. I think closing it makes it a lot more stable. But you know, if I position the cup and then I trial the hip and it's not stable, then I will take the cup out and reposition again. I'll change it. But you know, my test for stability, I will pick up the leg, pick up the femur, and I'll use my full body weight to push it up as high as I can beyond 90, 120 degrees, up as far into the chest as I can to make sure it's stable anteriorly. I will look to make sure the hip internally rotates to 45 degrees at 90 degrees flexion. I mean, my hip can't do that. So if the hip I'm operating on is stable at that level of rotation, it is very stable. and then I will fully extend the hip into hyperextension and externally rotate to make sure it's not going to come out the front. And if I'm doing those using my body weight, and I haven't even closed the capsule or repaired the fascia, then that's a very stable reconstruction. And I really don't get worried about spinal stability. I don't use hip precautions. I encourage my patients to ignore the stuff the physiotherapists tell them on the ward and to get on and use their hips. If you look online, there's lots of videos of patients going out to the gym 2 weeks after their hip replacements and doing silly things, and they seem to cope very well. There was a patient last summer who came into hospital 2 weeks after his hip replacement. He'd been out mountain biking, he'd come off his bike, hit a tree and broken his leg below his hip replacement. The hip didn't dislocate, he broke his femur. And this is 2 weeks after hip replacement surgery. That's amazing.
Yeah, yes, it is. Intraoperative question. The aim of the to put the hip in the true acetabulum, but when do you say that I will put the cup in high acetabular center?
Yeah, so it's to do with the patient's physiology. If they're elderly, if they have lots of other medical comorbidities as well, then I will position the cup higher up, because to try and do a more complicated reconstruction, it makes the risks of surgery go up, and the operation takes longer. So they have a longer anaesthetic, they bleed more, and they recover much slower. And they're much less likely to for that reconstruction to fail. Okay, if they're a younger patient, so they're 30, 40, 50, I will make a lot more effort to bring the center of rotation back down to where it should be, so that the hips is exposed to the normal sort of biomechanical forces and will have the maximal longevity, really.
With Crow4, it is very tricky to find the true acetabulum.
Yeah.
Would you go with the TAL as a landmark to find the true acetabulum, or there is another landmark for you?
So all the tissues become very difficult to identify in a Crow4. But what I do is I find the femur, find the trochanter, I follow the bone down to the pelvis, and I then follow the pelvic bone down south till you get to the native acetabulum. But if you look for the teardrop and you put your retractor in there, then you know where the bottom of the pelvis is, where the bottom of the cotyloid fossa is, and that's your landmark. And then you want to try and get your acetabular component into that. I mean, there's always good bone stock down there. It's not been loaded ever, but there's usually more bone there than often there is up on the ilium, where you're trying to find something which doesn't really exist. So yes, and I will use a very small cup. I'll position it down there. But then the difficult, that bit's relatively straightforward. The problem then is getting the femur back down into the cup. And there are, a number of papers out there of surgeons who do just will push the whole femur down, keep it intact, and then use a cemented hip, but sit the femoral component low in the femur to be able to reduce the hip, and do manage to get a reconstruction doing that. But I think you get a better biomechanical outcome if you osteotomize the femur. Then you can control the rotation of the trochanter to prevent impingement. You can and you can best restore the hip biomechanics. Either technique, you're not going to regain full leg length. So either way, you're still going to have a patient with a short leg at the end of it. And if they are telling you they want to have an operation because their hip hurts, but the reality is they want their leg to be the same length, they're going to be unhappy. And the complication rate from a Crow4 hip reconstruction is high. And there is a high risk you have an unhappy patient with an unhappy complication as well. So I'm very careful around those cases.
Brilliant, thank you very much. About the balance between medializing the cup and avoid ischiofemoral impingement, what is your trick to achieve this balance?
So if you're with a dysplastic pelvis, you often need to medialize the cup just to get the cup sitting under some good host bone. So sometimes I will ream through so I can see through the medial wall, and I'll create a medial wall defect. You can then use the femoral head, you can take some of the bone and use it, push it through your defect to create a new acetabular bone stock within the pelvis, and then put your cup in. And then you want to have increase the hip offset to move the trochanter away from the pelvis, but also because your abductor muscles are going to be pretty poor. They're going to be very weak. And the higher the offset, the less strength you need to actively abduct that hip. So if you increase the offset, you make the hip more stable, you make it, you need less strength to abduct the hip actively, and you'll get a better gait and a happier patient afterwards. Lots of these implants, so the Eterom hip I showed you just now, there'll be a limit to how far you can increase the offset. But the further you do, my experience is the happier the patient is, basically.
Okay, thank you very much. There is a question about a segmental or cavitary defect when you reconstruct crowd 2 or 3. When you intraoperative, when you find a superior lateral uncoverage more than 30%, would you use an augment or bone graft or change your cup implant?
So Crow 2-3 is less of a, the hip isn't as high, the reconstruction is less complicated, and usually you would be fine with just a standard acetabular shell. The case we saw at the beginning with the very steep acetabulum, all I've done is use a very small cup and bring it down as low as I can into the acetabulum and medialize it as far as I can to get some coverage. And that works very successfully. So I guess when I'm reconstructing a hip like this, I'm always thinking about the next operation. So if your first operation, you're already moving into augments and cages and screws and all this stuff, then when this reconstruction fails, you've got nowhere to go. If you start with the simplest solution, you'll have a faster operation, you'll have a quicker recovery, and so a happier patient in terms of their level of function. And you've got all these, plan B, C, D, E, if you have a problem during the operation, or if they come back 20 years later and the hip started to fail. So I guess my advice is keep the reconstruction as simple as you can, and I would sooner remedially and medialize the cup under healthy host bone and save my more complex augments for revision surgery if we ever get to that stage.
Okay, perfect. There's a question about the usage of fluoroscopy during dysplastic hip. Have you ever needed to use the X-ray intraoperatively?
So one of my fellowships was in Australia with a surgeon out there who used X-ray a lot during the operation, but we spent a lot of time during every surgery worrying about whether the fluoroscope was still sterile or not, and I didn't think it offered very much. In the UK now, we are moving towards day case hip arthroplasty, and within that pathway, there's no room for a post-op X-ray even. So the future pathway will be, we replace the hip, the patient goes home, and the X-ray is 6 weeks later, which makes me nervous now, but I suspect in 2 or 3 years' time, I'll be more confident with that. But with the revision work and the dysplastic hip work we do now, I will, if I'm worried that something's not going as planned, then I'll make a bigger incision and go and have a look and see what the problem is, because the X-ray is not going to help me fix the problem. It's just going to show me there's a problem, and I can see it by going and having a look for it.
Okay, perfect. Thank you very much. About the decision making from cemented or uncemented femoral stem, what is your advice for us to make this decision easy?
So the uncemented stem is much more expensive. So I use the uncemented stems for the young patients who I want to get the hip exactly right, because they're the ones who are going to want the hip to last 40 years or more. For older patients and for patients with very complicated acetabular reconstructions, I want to cement a hip in, I can change how high or low it sits, which way it points, the version, the varus and valgus alignment. I've got much more flexibility there. And of course, it's much cheaper. So for older patients, we use a lot more cement because we're not looking for something to last 40 years, but maybe 10, 15 years tops. So that's a much easier decision, yes.
That was the end of my questions. Hassam, do you have anything? Thank you, Mr. Sturridge.
Thank you, Mr. Sturridge, for this marvelous talk. Thank you.
Mr. Sturridge, please, I have 2 more questions, if you allow me, please.
Okay.
First question, do you prefer to use the dual mobility cup in dysplastic cases?
So interesting. I went to a talk in France 2 years ago, and a surgeon there presented his series of hip replacements in teenage and 20-year-old patients, all with dual mobility hips in them. And it made me very nervous because we don't really know the long-term outcomes of these implants. As I said earlier, I think the majority of our hips are very stable, and I rarely use dual mobility. I did one 12 months ago for a patient with who was very, very low demand, had a long femoral stem revision going down to the knee, and one of these complex acetabular cups with the screw in. So you screw it into the pelvis, and it was very medialized, and her bone quality was very poor. So rather than take the implants out, I cemented in a dual mobility cup into the metal shell, and that seemed to stabilize her hip, so no more dislocations. But beyond that, we don't see much instability anymore with modern implants. There's a lot of talk about using dual mobility for patients with neurological conditions like Parkinson's, or patients who've had a stroke, or maybe less reliable. But I think historically I've been worried about the implant disassembling. There was some work in the 90s that demonstrated that they could come apart, and that was causing problems for surgeons. I think the modern bearing is much better, and I'll probably start using them more now for patients who are having maybe their second hip revision. But for a primary hip, it's in a dysplastic patient, often the cup is very small. So if you want to put a 44mm cup into the pelvis, then there's no room for a dual mobility cup. And if you're going to use let's say you put a cup in and you want to use dual mobility, then it may be no bigger than using a 36mm head anyway. You may not get any more advantage than that. So I'm still quite cautious around dual mobility, but it is becoming more popular in the UK. I agree with that.
Yeah. My second question, sir, from your long experience, very long experience, have you been faced with a case of severe dysplasia that enforced you to use constrained cup?
No, I haven't. No. So I haven't seen that. So when I was a trainee in the about 11, 12 years ago, the constrained liners were very popular. My experience was that there was a lot of surgeons who were worried about hip stability, so they put in a constrained liner and didn't worry about the hip as a result of that. They assumed the constraint would sort any problems out. The reality was, of course, that a constrained liner results in impingement, and impingement in poor bone quality, particularly in elderly patients, leads to the cup failing and levering out quite early. So I do try and avoid those. Having said that, I replaced a hip, I think 2 weeks ago, for so a 60-year-old patient who has stage 4 lung cancer, and he had a large metastasis in the acetabulum above his above the hip joint. And I've used a cage reconstruction for that. And to get the cage in, I've lifted the abductors off the ilium to make space to put the cage into the defect. Now that's worked very well as a reconstructive tool, but the end result is that the hip stability isn't as good because the abductors are damaged. So off the back of that, he's dislocated, and he came in this morning for with his hip out. So I spent this afternoon putting it back in closed. But next week I'm planning to take the acetabular liner out and put in a constrained liner to hold the hip for the last 12 months of his life, in effect, really.
Thank you so much, Dr. Sturridge, for accepting our invitation and for sharing your experience with us tonight. It was a marvelous scientific night. Thank you so much, sir.